Welcome to the Point of Medicine podcast, brought to you by LearnNeuralTherapy.com. Doctors Ann Hill and Alana Gurvich team up to take a deep dive into the art and science of healing. This podcast explores cutting-edge approaches to the autonomic nervous system and its role in organizing fascia for optimal health. Each episode features conversations with leading clinicians who are pushing the boundaries of medicine, uncovering new insights, and transforming patient care. Join us as we bridge tradition and innovation to expand what's possible in modern healing. Just a reminder, this podcast is for educational and entertainment purposes only and not intended as medical advice. Please consult your healthcare provider before making any changes to your healthcare plan. Join us and let's jump into the next episode. Hi, everybody. Welcome back to the Point of Medicine podcast. We are exceptionally grateful to be joined by Dr. Cochran today. I want to say as a personal story, I have studied in Dr. Cochran's office and with Dr. Cochran multiple times. And every time the depth of knowledge that you have for injection and the passion that you have for patients is inspiring. So thank you so much for giving us your time. Let me introduce the audience to who I know. Dr. Cochran has a passion for education, guidance, and outside-the-box therapies. He received his doctorate in naturopathic medicine from Bastyr University and founded Interactive Health Clinic, which is a specialty-focused clinic in functional biological medicine, pain management therapies, integrative oncology, healthy aging. He's an expert in the field on therapeutic injections and intravenous therapies. He literally teaches all of our peers about these therapies. He has served as the medical fellow and a director of intravenous therapy at the Bastyr Integrative Oncology Research Center, Bastyr University's Cancer Research Center. Dr. Cochran is well known worldwide as a lecturer with International IV Therapy for Professionals, a group that specializes in education of physicians in intravenous nutrient therapy. He is also an instructor for many other therapeutic injections and a strong passion for both ozone and EBU therapies. He has an active consulting business with Heroes and OCBM, where he coaches physicians and professionals into optimizing systems for best results. As a keynote speaker and content creator, Dr. Cochran is dedicated to empowering doctors to build successful modes of outcome-based medicine. Thank you so much for your time, and thank you for joining us to have this really important conversation about injections in medicine. And do you want to?
No problem. We're excited to talk to you because we know you do so many different things. But first, can you tell us a little bit about how you got into the medical world? Tell us your intro story.
Yeah. So as a kid, I pretty much wanted to do something with medicine. So initially, it was a doctor, then it was a dentist, and then going through undergrad, I was doing chemistry and biochemistry and wanted to become a pharmacist, and kind of saw some limitations with that, hanging out with a chiropractic mentor of mine. And then I ran into a naturopathic doctor who actually was a pharmacist beforehand and kind of said, hey, you really should look into this. And then I went into naturopathic medicine instead because I felt like I could use the biochemistry and the chemistry stuff and actually apply that stuff versus sitting behind a counter and giving pills out to people, and also a little bit more dynamics in our toolbox than just drugs and surgery. So that's kind of the overarching story, but probably the passion that drove me into this initially was I did lose my father when I was 12 years old to melanoma skin cancer. And that kind of fueled the passion to figure out better solutions for health in general. So.
Wow, that's intense.
Yeah.
How much neural therapy do you do, and how'd you get into that world?
So neural therapy, I actually got into that world while I was in school at Bastyr. I kind of latched on to, you probably had him on here, Jeff Harris, and became his kind of right-hand man for quite a while there, teaching in that front, learning from him, and then teaching in that front with him for several years, and then kind of extrapolating out into different forms of neural therapy as well. So I do use it in my practice, especially for scars and ganglion injections. Probably one of my biggest passions right now for resetting the nervous system is called Neural-Ozone Therapy, where I'm actually using kind of a neurotherapy technique, but not using procaine all the time, but just straight ozone gas injected into different areas of the body, like we do with neurotherapy, to induce a a response, basically an autonomic response.
Okay, I need to know a lot more about that. So my first question is just ozone, no solvent, just gas.
Just ozone.
How much
Just ozone.
up for patients?
It depends on where we're injecting it. So if we're trying to get like an autonomic response, so I'll give you it's abbreviated NOT therapy, and this is actually something that we were doing neurotherapy, ozone therapy, and then another friend of mine, we were kind of shooting back and forth, and he knew of what we were doing in neurotherapy. He's a colleague, Dr. Dennis Harper, he's a chiropractor. And we kind of kept playing with it because I do a lot of also, it used to be neuroprolotherapy. Now it's called perineural injection therapy. And I was kind of blending that with some of the things with neurotherapy. And Dennis kind of took off, and we kind of shared minds and came up with some neural-ozone therapy techniques. So one of the techniques he came up with his chiropractic knowledge was what's called an adrenal reset. So you're basically doing shallow injections along that T11, T12 dermatome, and you want it to burn a little bit. So one of the nicknames one of his office staff said was it's called the fireball, because you get this brief, intense burn, and then it kind of causes that nice hot flush. But what it's doing, it's almost like when you put any stimulus into the body, it reflexes back to that organ system, right? So we're just going along the dermatome pattern, causing a little bit of a burn initially, and that reflexes back to the adrenals. And a lot of people find that their pain drops, but also they feel a little bit of an uplift with that. And if any of you know in medicine, the adrenal glands are massively important. So a lot of the times we just do that, and that will clear a lot of kind of the fuzz of what is the priority in the body. So that's one example of neural-ozone therapy. Another one we use it on the thyroid tissues. And then I've used it in lower dosages where I don't want it to burn in areas like the brachial plexus and different areas where we have nerve entrapments. And also just standard scar therapy, we'll use straight ozone too. It burns it's basically the strength of the concentration of your ozone is what determines if it's going to have that burn. So if we're doing 20 gamma for those old timers in the ozone industry, or 20 micrograms per mil for those of us that are new and kind of current, it burns. It's temporary, but it does have this burn response. But when you start dropping down into the 5 to 10 microgram area, you don't really get much of a burn effect at all. And we've used often like 5-6 micrograms. A lot of my colleagues use it for aesthetics on the face and stuff as well.
And it's just like a subdermal intracutaneous injection?
Correct. So yeah, just a very shallow injection. Unless you're doing any scar therapy like we do in traditional neurotherapy, you may need a longer needle to fish it into the scar. But for like the adrenal reset or thyroid, it's just a 1/2 inch, very short needle, just right underneath the skin type of injection. And even the brachial plexus, most of these injections are not using more than a 1/2 inch needle. So it's a very safe procedure to do.
Wow. So can you tell me, I'm just curious, like when would you decide to use procaine with the ozone? Or when would you decide to just use ozone? Are you mostly just using ozone now?
If I need to break up a scar that's pretty large and I'm using a combination where I need 20 to break things up, I will use procaine so that way the person's not in agony while they're going through this procedure. If I'm using a joint injection, I'm still using procaine as my main driver if it's a deeper injection. But usually for most of these autonomic resets now, I'm actually using a lot more ozone, or I'm relying on dextrose 5% buffered. I'd say if I need to do like a ganglion reset, or if I'm doing a tonsillar area, I'm still using some procaine in those areas. If I have an infection in the tonsils, I'm going to use procaine, ozone, and I may use another botanical in that tissue too, and kind of hit everything. But I've started using ozone and Dex 5 a lot more, probably in those really intradermal subcutaneous resets, and then saving the procaine for like the deep injectables like the ganglions and stuff, that I still rely on procaine for those.
Great. You do other injection therapies as well, right?
I do. Yeah.
Can you tell us a little bit more about what you do? How else do you use needles?
So, so I guess there's standard neural therapy I do in my practice, and probably less than some people do these days. Again, because I've kind of evolved, I mix it in, and then we use peri-injection or perineural therapy, or PIT, and that's using a buffered dextrose solution to treat inflamed nerves. And it's shallow injections, and I do use that. That's probably my main mover where I start with most people, and I find that I can move pain conditions and entrapments, and it's tolerated very well by people. Even if they have reactions to anesthetics, it's a very safe therapy. And some people that can't tolerate any of the cane drugs, that's my go-to for my anesthetic, is using buffered dextrose. And then another big player is ozone injections. I mean, I'd say dextrose and ozone has kind of been my main bread and butter lately, and then procaine's kind of there when I need it. Those are my main ones. In occasions, we'll go to more advanced therapies like PRF or PRP procedures, or using some of the biologics like exosome therapy, or I call them biological allografts. I really don't like the name stem cell because it's kind of deceiving for most patients.
Okay. Can you give us, I don't treat a lot of oncology. I'm just curious, like, what's your sort of like, what do you think about when you're treating a cancer patient with some of these injections? Like, what do you kind of focus on with that?
So I think the biggest ones I've used in oncology recently is anybody who's going through oncology. Obviously, it's a stressful event and you're going to have hormonal disruption. So one of the big ones is the neural resets, like the adrenal glands and the thyroid. The other big time I find injections extremely beneficial is pain. You have a tumor compressing an area, and your only options are opiate medications. That doesn't always work for people, right? I remember one instance that we had this woman that had incredible amounts of pain from a tumor that was basically growing in her brachial plexus region here. And they couldn't really do anything with radiation, and pain meds were barely touching it. And we were just doing perineural injection therapy with low dose, with the buffered dextrose. And we were doing that daily. And that was providing her enough relief that she wasn't in agony, because we're talking morphine was not touching this stuff. And so in those instances where they've already exhausted most pain meds and they're in pain, I find that the injection procedures are extremely beneficial for helping regulate pain, but they often have to be done pretty frequently to manage that pain in people.
Okay. Yeah.
Can you break down for us, like, one of the questions that we often get when we're teaching is, when do you choose which injection? And I think all three of us do perineural, all three of us do ozone, all three of us do neural. How do you prioritize what injection you're going to choose to do?
The biggest thing that I've found, and probably training wise, every single area that I think lacks the most, and I wish I'd see more involved, but as physicians, or we typically don't want to spend as much time in that area, is a good diagnostic workup. And we got our images and stuff that we can do. Yeah, we got our ultrasounds, but you still got to lay your hands on that patient and see what's going on. And I think that art is being lost a lot nowadays, of good palpation skills and intuition of what's going on. And we rely too heavily on images, and you'll see it where, if you do that, you rely heavily on the image, you go in, you inject that one area that you think was wrong, you get no response. It's like, what the heck happened? Or you'll see they went to some other doc and they were just injecting the heck out of that, and they missed the whole boat. So for me, I find that good orthopedic exam plus physical exam of touching the patient and seeing, what is this pain point? What does the tissue feel like? Does that reproduce the symptoms? Those are really key things. The other piece in my practice I do use some degree of muscle strength testing to determine, Is it a cervical issue? Is there something going on, in the a specific tissue? What is the priority overall musculoskeletal? You can simply do pretty good orthopedic exams for cervical weakness, and you can see with lumbar weakness, you can determine if there's certain areas that are off. One of the biggest exams I probably use from our basic orthopedic exams that I learned from my good colleague, again, Dennis Harper, is it's a 4-minute orthopedic exam. So it's a whole body exam in 4 minutes to understand what is really going wrong with this patient. So if they got basically they're pronating, do they have a short leg, and kind of isolating down to what is the priority. Most of the time, I'd say 80% of the time, I'm going to find out they got something wrong with the adrenals. So we do a neural-ozone therapy on that. That clears kind of the fuzz with them. Next is kind of figuring out, okay, where is this issue? Is it a scar? Is it a low back problem? Is it a hip problem? And that's really based on good physical exam. Can't tell you how many times I've seen low back pain where we've just kind of treated the low back, or I've seen people treat the low back and they've totally neglected to treat the iliopsoas tissues or the trigger points in the anterior pelvis area. That is over and over and over again. I've seen that too. So it comes down to that really good physical exam and history taking first, and then you can kind of pick what I need to do next. Now, palpation-wise, if I can reproduce a pain level with just palpating over the neurological structures, like the superficial nerves, 75% of the chance they're going to respond to doing perineural injection therapy. And I will say, hey, let's just do it. I mean, it's a harmless treatment. If you're going to get a response to this, you're going to immediately see change in the office visit today. So I will start with that, right? If they have a known scar, like a C-section scar or something that's really evident, that's also a priority point for me, because I know that's distracting the nervous system from healing properly. So those are kind of priority perspectives, because if I can get the nervous system functioning correctly, then the muscular system and the kinesthetics around those joint structures are going to function a lot better versus just going into the joint structure right away. And I find sometimes we want to do that because those are the sexier procedures. Let's do PRP or do an intra-articular injection. But most of the time, they're not necessary, or they're incredibly expensive for the patient, and they get kind of a small amount of movement. So I find it's better to treat the nerves, treat the outer neurological system first. And if you're then getting stuck after a period of a couple visits where it's plateauing, then go in and start doing your deep work, because now you've kind of have the structures a little more stabilized, and you don't have that hypertonicity of the tissue. You don't have that nerve inflammation around the tissue, and you just get a lot better results than just going straight in with PRP or ozone.
And so you see a patient, you can feel that myofascial, the trigger points, and you also see the scar. Are you going to prioritize one over the other? And then what solvent are you going to use for that prioritization?
Yeah, so if it's a scar and there's a lot of rigidity, a lot of discomfort there, I'm going to inject the scar. And typically I'm doing procaine with ozone, some combination there nowadays. If I have a tight myofascial tissue, then I'm going to track down the nerves that are innervating that. I really kind of got rid of doing standard trigger point, because most of the trigger point is, in the essence, it's the nerves that are innervating that muscle, the shallow nerves that are causing that muscle to be rigid. And if I just inject that muscle belly with procaine or dextrose, it's going to come right back on them. I didn't address the neurological inflammation. So I want to address the nerves first that are innervating that area. And my top agent there is going to be buffered dextrose, 5%. For those nerves.
Do you find that with doing a lot of the dextrose, do you find that you have to have people come back a lot, or do you feel like you can kind of get, with your palpation skills and the dextrose, you can sort of get it pretty quickly and get them out of it? Yeah.
The first 3 years, I always tell people this, and this is when I was learning with Dr. John Lithgott, kind of the creator of PIT therapy. I learned from him the first year at Bast year, and then I was so ambitious, I decided to fly down to New Zealand and do a master class with him among 3 other docs after that. First 3 to 4 years, you felt like you were doing a shotgun approach, kind of just shooting around the nerve and hoping you're hitting something. And the more you did it, so about 5 years into doing it, you really understand the anatomy that they didn't teach you in med school at all. And then you start palpating, you can actually feel the stuff that you thought he was crazy, telling you this. And then if you've done some ultrasound, you can say, oh my gosh, it's on ultrasound too. This is real stuff. That 5-year mark, your results just increase. So less injections, less of this guessing, let's just carpet bomb the area. And I felt that your results were much better. So you could see things in that visit if you were on the right track or not. So to give you an example of that, patient comes in, they have a sore shoulder. I do a full shoulder exam. I also palpate the nerves around the shoulder, and they got neurological tenderness upon palpation, and they got restrictions of specific nerves. I'll basically tell the patient, I think there's obviously neurological inflammation here. I would propose let's start with this and see how much we get movement with. We'll have an answer in this first visit if it's going to respond or not. If I get no change in your symptoms, that means I missed something and I got to go back and think, or I got to do a deeper injection on you next. But if I get a response that's 50% or better, we're definitely on to something. Even 25%, I'm pretty happy with, because I want to just see how you did over the next day or two. Those people, again, we'll treat them, and then most people, I would say your average is about 4 to 6 sessions to get their pain levels down to an acceptable level where they're comfortable at. And that may be 0, that may be 10% or 15%. Back. Most people fit into that category. We've all had those miracle cures. I had a 28-year-old electrician who was drilling like this, and the drill caught him and went like that with his shoulder and tweaked something, had all the typical MRI, orthopedic, oh, we don't see anything wrong with you, had pain for over a year. And literally we did one procedure with PIT and it totally went away, never came back again. And you will get those occasionally, those magical, they're young, they're healthy, they haven't had steroids put in them yet, they're not smoking like a chimney, they respond and heal very quickly. It's the patients that come into you that they've had multiple steroid shots, they're not healthy at all, they treat their bodies like a garbage dump, or they're on opiates or pain medications. They're not going to fit that average 4 to 6 treatments. They're the ones that you're looking at probably double or triple the amount of time, no matter what regenerative injection you're doing. It just takes so much longer with those patients.
Did you do, before you went to Bast, did you do like any form of body work or anything like that? I'm just curious.
Not much, no. I actually, again, a lot of it was chemistry, biochem type stuff. So
yeah. I just love what you're saying about the palpation and how important that is. And that's what I think Ilana and I talk a lot about, why we love doing PIT therapy so much, is because it's a very palpation-based technique. And I agree. Like I remember learning with Dr. Liftgott, and he was like, oh, maybe 14 or 16 treatments. And I was like, wow, that's it's a lot of injection. But I definitely feel like, yeah, over the years, you get a much greater sense in your own palpation skills of bodies. And I love what you said about the anatomy that they don't teach you in medical school. I feel like there's something different about the anatomy when you're touching it, that it's just not in any charts or, textbooks or anything like that. So
I think, some of the things, back to not having it before medical school, but a lot of the courses I did take were like visceral manipulation, cranial sacral therapy. A lot of those therapies kind of get you tuned in to understanding the minute, small touch details. That was a good foundation in school. And then hanging out with a lot of these mentors that are, especially like old-time chiropractors who really understand anatomy, that's been especially very helpful for the dynamics of physical exam.
Do you pair your injections with other modalities? Like, do you pair your injections with spinal manipulation or orthopedic manipulation, or do you use anything else, or is it really just injection based?
So if a person needs manipulation, I will do it in my office. I know how to do that. Yeah. And most of the time, the people that I have come into my office, and I'm sure you do, they already have like a chiropractor doing something. And most of the time, they're pretty good at what they do. Occasionally, you get that one that just wails on them and has them come back all the time. And they're like, oh, it's not holding. It's not holding. And then you inject them, and all of a sudden, they go back to the chiropractor. Oh, man, things are holding better. I wonder what you're doing. So a lot of the times, I don't end up doing it. But if they don't have that body work support, then, and I find that there's a restriction somewhere, I'll do an adjustment on them and an injection when I feel it's necessary.
Other naturopathic modalities, like, do you have most of your people on herbs and topicals are you using anything else, or is it really mainly you're just using your injections to do your heavy lifting?
Most of it is that for at least the manual therapy. We do have also PMF in our office, so pulsed electromagnetic frequency, and I'll use that for people that are needle phobic if we need to get some pain relief, or I'll use it after an injection just to kind of improve if I put a lot of fluid or something in a tissue, I'll kind of improve and distribute that solution around. We also have a shockwave that we'll use in the office too. So we do use those tools quite a bit in our office.
And it's injection first, PMF second, or PMF first, injection second?
If I have, depends on the area. So example, if I have a patient with your typical plantar fasciitis presentation, a lot of those will find that there's more to it than just obviously the bottom of the foot. There's also issues up into the calves and stuff. So typically we'll treat the injectable. We'll inject along the nerve roots for that. Make sure there's nothing in the back. Make sure that their feet are not pronating or supinating, because I see a lot of those, they need either arch or heel support. In the bottom of the feet, though, I really don't inject people anymore. I'm kind that way. I used to inject, and I got a lot of people swearing at me, and I was like, there's got to be a better way. And you get results, but it just wasn't moving the needle as nice for the amount of pain people had to go through. So I found actually using shockwave on the plantar surface is a lot more tolerable for people. It still hurts, but it's not a needle going, around the heel tissue. So usually I'll combine shockwave in that instance for people. PMF, I find is most of the time I use it either alone if a person doesn't want injections and they want some relief, or I'll use it after my injections, kind of to calm down some stuff that I might have inflamed up a little bit. The other modality we do use a lot is, and you kind of alluded to it, is we use a lot of IV nutritional therapy. That's one of my bread and butter things that I do in my practice. And a lot of these patients, they're coming in, and you've probably seen it too, is they eat the bland, beige, shitty diet of the US. So they're all like deficient and everything. And then they wonder why they can't heal well, or they're, constantly injuring themselves. This is a nice little cheat code kind of to getting their nutrients in them so they will actually respond to your regenerative injection. So we do pair that up when necessary, when we hear that history or lab workup that shows, we really need to do some work here.
Do you remember learning a lot about chronic pain in medical school?
I think there's one class that maybe we talked about it. It wasn't really that helpful. I don't know, medical school was more of a how do you keep you safe so you don't hurt somebody type of thing, but not how to make people well necessarily, unfortunately. Yeah, it was a glimpse. I don't remember much.
I don't remember we got much in our school either, but I find that that's kind of what I'm drawn to now too. Like focusing on that.
Acupuncture, I feel like I probably got more than everybody.
Yeah.
What do you do with acupuncture?
The one thing I will say differentiating though, when a patient comes in, and I keep this general rule, is if a patient has a 4-quadrant pain issue, they're probably not going to respond to your injections unless you're targeting like ganglions or the autonomic reset. It's not like you can go, unfortunately, walk in and inject every single spot. Patient's not going to like you. So 4-quadrant pain, they have some metabolic issue that needs to be addressed at first often. And when you're addressing that issue, then it may simplify down to one or two areas that need to be addressed with your injections.
So when did you start deciding to teach, and what inspired you about that?
So I was actually teaching my last year at University of Washington in chemistry. They had a course that they offered as for teaching. And so it started out teaching high school chemistry, and then you worked into the end of the year teaching a section of, freshman undergrad chemistry TA section. So I got to do that the last few quarters there and came out kind of with this little teaching certificate thing. So that was kind of the first part. And then I liked it so much, I kind of kept going through in undergrad or graduate school helping out. And then after grad school, I was doing a little work at Bastyr, but most of it was supportive because, I'm a new grad and you want to work, right, as you're getting your clinic started up. But I also understand that I couldn't stay at the school and teach something I don't really know. And, I don't have clinical experience. If I'm not helping under somebody else who has that, why am I here? I'm not ready to teach the big times. At that time, I was doing my clinical practice, but also teaching, nurses, anatomy, physiology, nutrition type stuff at one of the nursing community colleges. And I did that for probably 4 years in that avenue. And then it kind of just kept growing to asking to teach the IV department with Bastyr and then teaching in several different dynamics. Yeah.
Are you still teaching for Bastyr?
I'm not. That's a different story, but I went on to bigger and better things for that aspect. I think one of the things, and it's not just at Bastyr, but it's all schools, medicine in general. And I think it's a really big tragedy. And I've brought this up to a lot of people is what they've done is they've gone to a model where you either graduate and then you immediately teach in your core faculty without any clinical experience growing your own practice, or that's all you do. You went out, practice for a couple of years, you come back and you're just core faculty. I've never really agreed with that model because you know nothing else other than what's happening at the school. So I think what needs to happen, and unfortunately none of the schools are really doing this model anymore, is we need to go back to the old model where the clinician most of the time still does clinical practice, and then they teach one or two classes at the school to provide that, clinical support and mentorship as they're going through. And I think we've lost touch with that a lot. And we're seeing that in the, I would say I'm seeing that, and a lot of our colleagues are seeing that in the caliper of students that are coming out, not only from naturopathic school, but other medical schools too. They're just not really as keen on having good clinical skills because they're being taught just from a textbook model.
That's really interesting.
Well,
what about? Oh, sorry.
I supervise residents, and I have for over a decade. And the quality of residents that I'm supervising are still really very high quality. Like the clinical thinking is interesting. The curiosity is really there. Do they have a knowledge of naturopathic medicine? No, they're trained as primary care right now, and conventional primary care. But do they have a passion for the medicine?
Yeah,
yes.
They
but
do.
I think college is also struggling. Yeah, it's heartbreaking and concerning, I think, for all of us because we don't know what the future holds.
Yep.
Yeah. When did you do you teach, like, do you run your own seminars? You do run your own seminars for injection therapies,
tell our
right?
audience what you do, how they find you?
Yeah. So I have taught several years with international IV therapy for just IVs. And then I teach my own seminars on ozone injections and other injectables too. And then I also have another course I do on EBU and other things. Kind of those are the small group things that I do. PIT, I was doing a lot of the master classes with Dr. Lifgott when he was coming over. I'm supposed to be doing a class. I just haven't sat down, and like most of us, it's on the to-do list of need to do it, get it done, but just the list is massive. So that's coming. I'm going to plan on doing something with perineural injection therapy. Somebody will force me to do it, or I'll just do it. because there is a group of us that have been out, like myself, Jeff Harris, and a couple of us that have gotten kind of his blessing as you're a certified teacher in PIT. So that piece is doing it. Otherwise, it's kind of been more of these classes that I do with Frontiers of Ozone, and then we got another one. I'm leaving in 2 days to go teach people in Mexico how to do some injections with all this cool stuff too. So, yep.
So when you went out and you studied with Dr. Lifcott, when you did the master class, it was you and 2 other physicians, and it was similar to the way he did all his other master classes. Patients would come in every 30 minutes and get injected.
Yeah, so it was 3 other physicians. One was from Vancouver, and him and I actually gave a presentation 2 or 3 years after that in Hawaii with Lisa Smigel's group doing a IV mannitol lecture. And then the other doc was from Hong Kong, I believe, and then there was one from Italy as well. So it was just 3 others. Vancouver, it was just us. We stayed actually at a house there, and he was actually having his patients come in, and we do patients like we held in the U.S., but we also did a lot of review of the anatomy and practice. And in that context, we were there until because we're at the house, so we were working until 10 at night most of the time, and then up early. That was back when we were young, and I was young and stupid at the time, when it was like right out of school, don't have much money. Let's just fly down to New Zealand and spend 3 or 4 days and then turn around and fly back. No time to stay down there and enjoy. And there's no way I'd want to do that these days. You'd want to actually go and enjoy and spend some more time, but it was great back then.
Cool. Well, we hope that you get your perineural injection therapy classes together soon.
Yep.
It's definitely been such a game changer for pain for people. I think more physicians need to learn that. I'm just curious because, I see mostly I see lots of pictures of you on Facebook in a plane. So you kind of travel all over the place. Can you tell us, it sounds like you're doing some international stuff too. What is it like teaching in other countries? Like, I know in other countries, like some docs are, getting some of this injection therapy already, but what have you found in terms of interest?
Yeah, so biggest countries I've been over in Europe. So last year we were in Portugal teaching a kind of a healthy aging course, and then London, and then I've been over to Taiwan and obviously the New Zealand area quite a bit. So Asia and then Europe quite a bit. And then we're planning on going to Spain to work on an ozone project in a couple months too. The interesting thing is a lot of the docs over there, they're really intrigued to learn new things, especially if it's a relatively affordable, cheap therapy to do. There are a couple countries that, for like ozone, for example, in Taiwan, they're really strict on, they have to have a study in their country to be able to use the therapy. So ozone's like, you can't have the machine yet. So that's, unfortunately, you run into boundaries in some countries. Other countries, they're pretty open to using it as long as it's not harmful and it's inexpensive. They're not big on using PRP or stem cells in most countries. You may see that in like South America for medical tourism and stuff, but a lot of these countries, nobody can afford to do those expensive high-end procedures. So they're trying to use the lowest cost thing possible, which is dextrose, standard prolotherapy, or if they have ozone, those are kind of your mainstream regenerative or type therapies that most people are using. My buddies in Taiwan, I've lectured online with them quite a bit. They have basically one of the hospitals, they use prolo and PIT therapy and some of the neural therapy, and it's like a whole floor. And it's very cool because their hospital system is, it's basically more patients go to the hospital, the more they get paid by the government type of thing. So there's this competition to kind of be innovative in the hospital systems. And so it's a whole floor, and these docs are doing injections, whether it be PIT, ultrasound injections, but really they're just using dextrose and maybe an anesthetic. That's it. They don't have ozone. And then right across the hallway, they have the physiotherapist. So they'll literally get they'll be working together. You may have an injection and you're getting physical therapy the exact same day. And then down the hallway from that, they have the IV area where they're doing a couple infusions. So people will literally come in and they'll get all that done. And the IVs there are not super complicated for cost. So you're maybe doing like vitamin C and a couple collagen supportive nutrients, and they're smaller volume. But that's what's going on, at least in Taiwan, is they have like this whole intricate system of moving people in relatively quickly in high volumes, but having a really good team dynamic of everybody on the same floor doing the same thing. If you go over like to Europe, it's kind of more the private practice style is what I've noticed, of people doing different therapies there. And it's, when you get outside the US, I feel like it doesn't matter what your degree is or what your credentialing is. It literally, if you have a brain and you're clinical and you can think, you're on par with everybody else, which is really nice. Versus in the US, we kind of have the stigmatism of picking on people based on your degree or where you went to school or certificate. And it doesn't feel like that exists when you kind of leave this country. That's one of the senses I've seen.
That was, I think, one of my favorite conferences was Schallenberger in Reno. And I feel like every single doctor in there was from a completely different country. Like it was like 70 people and they were all like, we were from, every country was represented. It was pretty amazing. It was really fun.
Yeah, he has quite a bit of those. And then the other one is the big A4M. There's a lot of people from around the world there too.
Cool. I have not been to one of those, but it's on my bucket list to get out there.
This is my second year lecturing there, and it's fun. There was, by far this year, the attendance doubled from last year. So there's definitely a shift of practitioners looking for something new.
Yeah.
There had to be at least 6,000 practitioners there this year.
Wow. That's amazing. That's pretty incredible.
It is exceptionally inspiring to do what we do. To be able to practice with the creativity, first of all, that naturopaths can practice with is like, I'm so grateful. I come from a big medical family and I see how not having a standard of care allows us to offer patients exactly what they need and not just what an algorithm tells me that they need. What inspires you? Inspire us with what inspires you.
Me pushing the needle as much as I can to get the best outcomes possible. So it may literally be, to be honest, when I go to conferences these days, I'm like, I think I learn more out in the hallway talking to other people than sitting in and listening to somebody chat. And usually what happens is when you learn something, you kind of bring it in and you say, okay, how do I fit this into my treatment equation to improve results? And so my inspiration, I think, is how do I keep moving the needle to get better and better results with patients to tell more and more people and help more and more people. The more successful we are in the field and the more people we can help ultimately. And so that's what inspires me, is to keep learning new things, keep being humble and learning, oh crap, that didn't work out as well as I thought it would, or maybe that didn't work, so we need to change how we're approaching this. It always is changing, and that's what keeps it interesting. One of the big things I really am kind of humble about right now, and I've always had my suspicion, is everybody's NAD happy, right? Oh, NAD IVs everywhere. And I've known for years, I'm like, it's a tool. It's not magic, and it can cause a lot of harm if you don't use it properly. We're getting new evidence that came out this year that showed if you get excessive NAD pooling, it causes cardiovascular disease to increase. So there you go. It's like, no, not necessarily. It's those little nuggets, if you can try to pick up on and learn and look ahead of time of what may be right, what may be problematic, that gets me excited. It's nerding out on those things.
And being careful, that's good. Not jumping on every bandwagon that drives by is perfect. So
correct. That is a really good point. Because there's a new bandwagon out there and we're looking at it and I'm like, I don't think that's right. but keep an open mind and basically look at it and see, does it have potential or not? And then either throw it out the door or maybe adopt it eventually.
Great. Okay. Any other questions, Alana?
No, I appreciate your time and your knowledge. And actually, I appreciate what you give back to the profession, because I also believe the more we as physicians help people, the more we change the world and the more we inspire our field. And I personally have a huge amount of debt for the fact that I am a naturopath. I have a huge amount of debt to the naturopathic profession because it gave me my soul's destiny. And so I appreciate you carrying that same energy and just giving it back to the profession. So thank you.
And I think we're at a time now in our profession where we're making a movement in shaping how the conventional medical field is forming, because they're looking for answers they don't have. And we're seeing a lot of that pivot now. And one of the things that's kind of going to be exciting, but evolution's going to need to catch up with, is a lot of this AI stuff. They're looking at what we're doing and they're saying, oh, all this environmental stuff, all these things you're doing, let's put that into AI and help us get results, and we can track these results. So if you're not kind of inspired or innovative or doing things cutting edge, it ain't going to cut it to be a walk-in clinic at Walgreens anymore. You're probably going to lose your job, unfortunately. But it kind of pushes everybody to a new spot or a new place of thinking, I think. So I think it's always a good thing. We just have to evolve and adapt to it.
Yeah.
Thank you so much for your time. We are so grateful that you came to join us on the Point of Medicine podcast, and then we'll talk to you soon.
You're welcome.
Hang on.
Thanks for joining us today. If you like the episode, please like and subscribe to our channel and review us on your podcast players. Also, if you think this episode is helpful to some of your friends or colleagues, please share it widely. If you are curious about learning about neural therapy or other injection techniques, check out our courses on learnneuraltherapy.com. We'll see you next month for our next installment of the Point of Medicine podcast.